And bonjour, this is Bruno LARVOL. I'm here with Dr. Mark Gramling from the LARVOL Group. We are going to talk about AI as it applies to cancer data. This is our podcast, and usually we make it 30 minutes. Today we're going to try a new format, which is a 15 minutes format. And if it works well, maybe we'll adapt it moving forward. So before we start, I'm going to ask Mark actually to in it. Number one, to introduce the LARVOL Group in a minute. Number two, to introduce his data platform that he built, which is called LARVOL CLIN. After that, we're going to talk about how we plan to use, and we have started using, generative AI, LLM, in the context of our cancer data. Our goal today is to share with our audience our learnings, actually both our successes and our failures in applying LLM to our oncology data set. So Mark, to you.
Sure. Thank you, Bruno. And you cut a bit, so I think I was introduced with introducing LARVOL Group and CLIN, so I'll go from there. So LARVOL Group overall, we are a provider of software as a solution and also other solutions in the data science field for pharmaceutical companies and healthcare companies, whether that be competitive intelligence, data on trials, whether that be looking into key opinion leaders and where they are in the field, whether that be specifically, we're very focused on oncology and where that data sits. And speaking into that is the second point. CLIN is a major focus of ours, and CLIN is a platform focused on oncology, really with three buckets, if I could say it that way. Being that one place of all of the publications, all of the relevant public data on trials, whether it be ct.gov, UDRA-CT, or globally, point one. Point two, or separate bucket, also tracking more than 3,000 oncologists and how they respond to data releases in oncology for all of those trials and the conferences. And third, we also put the outcomes data for all of those trials, all of those data releases into a common data model to look at outcomes, whether that be hazard ratios, Kaplan-Meier curves, time to event, non-time to event outcomes data as well. So I did that as brief as I could because I realized we're in the 15-minute format that we're trying out. So that's how I'd introduce it, Bruno.
And as you get ready to share your screen with CLIN, I want to say a quick couple of additional things regarding LARVOL CLIN. So the audience can think about CLIN as a big data bucket with anything that is published, is known publicly about cancer research. So we have a team that is creating that data, moving it to a common data model, and now we're selling that data to various people in the drug discovery and development field, especially pharmaceutical companies. And of course, when we have all of that data, the question is, what can you do with it? Especially, what can you do that wasn't possible before LLM, before generative AI, and now is? And it's hard to keep in mind that LLM is just appeared like a few months ago, a year ago, right? It is so fast, and it changed so many things. Of course, AI has been around for longer, but there's something absolutely new, and of course, that created a ton of hype about generative AI. The question is, what is generative AI good at, and what is not good at? And we tried a number of things, and we failed in a number of areas, actually. And now we're much wiser. So we want to share with our audience what we learn in applying that type of AI to cancer data. So initially, we thought, well, we have a lot of very structured data. What we can do is apply LLM to that structured data. we have, and as we speak, actually, Mark is going to show you some of the analytics. What's the Kaplan-Meier curves for those of you who are experts in cancer data? You know what I mean by survival data. Another type of data is the forest plot. They look like forest a little bit. They're plotting of hazard ratios. We thought generative AI can help. Maybe can help extend and project these curves, or maybe predict some of these hazard ratios. And now my view is that that doesn't work. It was silly of me to be maybe a little bit too optimistic about what generative AI can do. And I know in theory you could say, well, it could generate the rest of the curve, right? We have, let's say, immature data, Mark, and generative AI can sort of predict how the population of patient will do later on. Well, I don't think that works for several reasons. Number one, generative AI is not very good at facts. It hallucinates. It's good at generating things. It's good at summarizing things. It's great at classification. It's not good at predicting. And I know it predicts the next word or the next pixel, but it's not good at predicting anything that needs to be accurate, that is not creative. In science, you don't want to be creative in extrapolating data. That's what got the Harvard folks maybe in trouble, or maybe the president of Stanford in trouble. You don't want to be creative when you write scientific material or when we talk about scientific data. So generative AI, it's too creative. It hallucinates. In a way, it's a large textual model, and our field here is actually a small structured data model. That's what we need. So we realize that for many of the kind of data applications that we were looking at for LARVOL CLIN, Gen AI cannot help. So we were a little bit disappointed, right, Mark?
I think in the larger, grander scheme and the longer term scheme, maybe I'm not terribly disappointed. Maybe I find there's something there in the future, but I'll agree with you in the near term, Bruno. Yes.
Also, maybe you were a little bit more, I would say, measured in your expectations about what Gen AI
I
could
was
do.
more measured in my expectations, frankly, as we were working on that. Full
All right.
disclosure.
But so the audience say, oh, well, that's a letdown. Well, so first conclusion is podcast lesson to share. Um, Large language model doesn't work with small data set, right? A large language model is there to generate either the next word based on huge textual data set or the next pixel in sort of stable diffusion, mid-journey type applications. That's not what we do in science. That's not what we do in cancer science. So after getting over that disappointment, we found other applications that we can share with our audience. And I'm, again, very optimistic about it. Now, we haven't proven yet how powerful it is, but we're pretty confident that it's going to work. And maybe in one of the soon-to-be podcasts we'll prove it. But for now, we're going to show you essentially our roadmap. So we know that large language models are good at two things. I would say three things. Well, at Q&A, chatbot, like ChatGPT, at summarizing, and at classifying. Right? Now, we have a lot of data in CLIN, but we also have a lot of text, actually. And in particular, Mark alluded to the fact that we have a lot of text related to key opinion leaders on X, on Twitter. So I'm going to ask Mark to give the audience a quick explanation of the kind of data we accumulate centered on clinical trials as it relates to digital opinion leaders. And then I'll come back and say what we plan to do with that data.
Sure. So there's different ways of looking at this by trials or in different machinations. But as I was pulling this up, I'm just going to ask because we're there. Obviously, this is a hugely impactful conference. And just to summarize, if you will, I'm just going to go with Ash what we do and how we consolidate, as Bruno said, chatbot summarization and things of that nature, we think are especially applicable to how oncologists, and we look at the social media activity of more than 3,000 oncologists on Twitter or X as it's now called. And I'm just going over here to Ash to show some of the summary data that we follow all of their tweets, or I don't know if they're called tweets or X's now. Frankly, I don't know the term, but you can see the volume and the sentiment here that we currently do manually, but we want to, as Bruno will say, do in a more tech-enabled fashion, how they're responding to and the volume they're responding to data releases on particular trials. And if I were to click through here, this is showing individually by handles on X, how they're responding to trials from this particular conference individually. And then further, how people are reacting based on the even sponsor of the trial, industry sponsors especially being important. And we do different ways of analyzing that social media reactions and the volume from the conferences. But that's really the main point from this conversation, is showing how people are responding to that. And then maybe just to drill down quickly, because I neglected to show it as I was going through the analytics, but to get down to brass tacks, this is what we mean in terms of what we curate on CLIN. These are their reactions on social media to data releases by trial, by abstract, etc. So you can see that briefly here. So hopefully that sets up visually a little bit of what we mean by social media influencers, aka oncologists, key opinion leaders, in terms of what we do in CLIN. So there you go.
So the starting material we have is a series of tweets, X posts about a clinical trial, about a research results that was just disclosed at a conference like ASH or in a publication. That's a starting material, but it's not comment from anybody. It's comment from a curated list of 2,600 digital opinion leaders, people who are oncologists, and our team essentially harvest their commentary. And right now they're manually vetting that tweet is about data, is about cancer data, what trial it's about, and also our team is assessing the sentiment. Okay, negative, neutral. We call it not rated. Most of them we stay on the fence, and then positive. Now by the way, we're about to add a fourth sentiment, which is important in the area of clinical research, and is that it's not only positive, meaning the clinical trial worked, but it's practice changing, meaning that the experts in the field feel that the data is so good in the context of their practice that is going to change the way they treat that cancer type. Practice changing. So we will have 4 sentiment, and we plan to have even one more classification of these tweets, which is extracting the way the KOLs, the key opinion leaders, talks about adverse events, toxicity of that drug, and be able to extract and curate that separately from their conversation. So think about the LLM's role here as listening to essentially the entirety of that qualified conversation that takes place in real time about the new data and extracting from it an overall sentiment, whether or not it's going to be nudging or changing the practice of medicine for that tumor type, and even the conversation about adverse events. And so we're very optimistic that our effort in LLM can not only summarize that overall sentiment, but classify it. And therefore, the type of analytics that you've seen can be generated more efficiently, more cost efficiently, and actually even more accurately. I used to say to our customers, our analysts are going to do better than any script, any software, any natural language processing, any AI. I was wrong, I think. I think that now is the time to get LLM to do it. Now, in a few weeks or months, we probably have another call and show you how it worked. I'm optimistic, but Mark knows that I'm often optimistic. But I think it's going to work very, very well, and I think we're going to be able to extract all of that information from this conversation and serve it to our customers as well. So bear with us. Now, I want to tease you with one more thought, and then we'll close the call with Mark. The thought is that if you have all of the tweets about clinical research from essentially all of the active, validated oncologists on Twitter, could you create a complete synthetic oncologist chatbot? Right? In oncology, people are talking about creating a synthetic control arm in a trial. Well, here, if we take everybody's tweet, maybe we weight based on their influence somewhat, can we create a chatbot that would answer questions or talk or behave, have opinions like the synthetic opinion leaders? So, Mark, what do you think? Are we going to be able to do that as well?
Well, I think there's a lower hanging fruit and there's a higher hanging fruit. The lower hanging fruit is probably in the context. Well, maybe there's three elements. The lowest hanging fruit is contextualizing and constructing reactions to a particular trial abstract from the conferences we were just looking on. Point one, putting that together. I think the next level is synthesizing reactions to it at a trial level, all different types of publications for that. I think the highest level of that, which is maybe the most difficult, is a very broad synthetic DOL, as you described it, let's say in a cancer area. That's probably the most audacious application of LLM, of generative AI. So that would be my reaction in that regard. So
we love OncoData, we love LLM, and of course we love our audience. So next week we're going to have a special episode of LARVOL ONCO DATA. We're going to focus on preparing for ASCO GI. So that big conference in San Francisco that's going to take place the 17th of January. And we're going to show you how CLIN, this platform, can be used with real data. It could be a real practicum, so to speak. We're going to show you how this platform, that is accessible for free for non-commercial use, by the way, can be used to prepare for ASCO GI. So I hope you join us. Au revoir.
cheers.